Dear esteemed chairs, dear audience, dear colleagues, welcome to my 6 months progress report presentation. My PhD topic is about key differences in sex-specific outcomes after anterior cruciate ligament reconstruction. My name is Krisztina Kornis. I work as a physical therapist, and I'm currently a first-year PhD student. Here you can see the individuals in my research team who are supporting me in my PhD journey. And I came here with a clear vision last year, September, when I started my PhD, which is to revolutionize physical therapy assessment and treatment with innovative methods. And my mission to achieve my goal is to explore innovative strategies in physical therapy by conducting research. To achieve my goals, I have 2 ongoing projects at the moment. Both of them are analyzing sex-specific outcomes after anterior cruciate ligament reconstruction surgery with a particular focus on graft failure and arthrofibrosis. Let me introduce you both of my projects after each other. My first one is about investigating the effect of sex on the outcome of anterior cruciate ligament reconstruction surgery. This is a systematic review and a meta-analysis. Anterior cruciate ligament is a double-bindle dynamic ligament which maintains the knee stability during dynamic movements. Just only in the United States, there are more than 100,000 ACL reconstruction surgeries in every year, and the second incidence of ACL injury after the first reconstruction is nearly 6 times higher than in the healthy controls. Despite the high prevalence, while investigating the literature, I realized that different sources publish different results. Some authors mention that both sexes have a similar chance of experiencing a second ACL injury, while some papers mention that female players have a higher rate of secondary ACL injuries, and some journals stated that males have a trend towards higher re-injury rates. We also know that anatomical differences, hormonal effects, biomechanical factors, and variations in the neuromuscular control can also influence the success rate of ACL. But what are these factors and what are these effects? Here you can see the quadriceps angle, which plays an important role in knee biomechanics. Due to anatomical reasons, we know that females have a higher quadriceps angle, and one of the most common alternate movement pattern is dynamic knee valgus. And dynamic knee valgus is often associated with a higher quadriceps angle, which can increase the risk of non-contact ACL injuries in female athletes. We also know it from the literature that higher estrogen level can increase the risk of ACL injury due to the hormone's effect on laxity and neuromuscular control. Some authors already mentioned that there is a need to recognize the different factors that can influence the success rate of reconstruction. And my aim is to identify if there's a difference in the clinical outcomes after ACL reconstruction between males and females. My clinical question that I would like to answer here is if there is a difference between males and females in the clinical outcomes after anterior cruciate ligament reconstruction. In my PICO framework, I aim to investigate patients who had undergone ACL reconstruction surgery and rehabilitation, and I would like to compare males to females. I identified 2 outcomes. The first one stands for the graft failure outcomes, like graft tear, revision surgery, or return to sport failure. And my second outcome summarizes the knee instability outcomes. I hypothesized that females have worse clinical outcomes after ACL reconstruction compared to males. And if we can prove this hypothesis is true, then we can immediately start developing sex-specific protocols for rehabilitation plans, which may enhance the success rate of ACL reconstruction. Here you can see my search key. And for my search key, I identified 4 domains. The first and the second stands for the ACL and the surgery. The third domain summarizes the graft failure outcomes, and my 4th domain stands for the sex difference. The search was conducted in 3 databases, and after the search, we ended up having 11,500 articles. After the duplication removal, we had 7,700 articles, and based on the title and abstract selection, we ended up having 2,000 articles, and at the end, we involved 59 articles. The topic passed the feasibility check. The Prospero was submitted at the end of November. Duplication removal, title, abstract screening, and full text screening is completed. And currently, we're working on citation chaser and data extraction phases. Let me move on to my second project, which is investigating the effect of sex on the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction surgery. This is also a systematic review and a meta-analysis. Arthrofibrosis is an abnormal fibrotic response which can lead to excessive scar tissue formation in the joint. The most common complaints are discomfort, pain, and limitation in the range of motion. The incidence of arthrofibrosis is between 1 and 12% after ACL reconstruction in the United States. And while most of the patients can be treated by non-surgical management, like physical therapy and mobilization, around 4% of the patients need additional surgical treatment, like revision surgery, scar tissue removal. Arthrofibrosis can significantly impair functional outcomes and may prolong the rehabilitation. And my aim is to identify if there's a difference in the prevalence of arthrofibrosis after ACL reconstruction surgery between males and females. My clinical question that I would like to answer here is if there is a difference between males and females in the prevalence of arthrofibrosis after anterior cruciate ligament reconstruction surgery. My PICO framework is pretty similar than in my first project. Instead, here as an outcome, I identified arthrofibrosis and revision surgery due to stiffness. I hypothesized that arthrofibrosis is more common in females than males after ACL reconstruction surgery. Why is this important? Well, because by understanding sex-specific risk factors for arthrofibrosis, we can guide the development of rehabilitation programs that are optimized for men and women. Here you can see my preliminary search key. The preliminary search was conducted in 3 databases, and it led me to find my key articles. And our main focus was to find articles which can provide separate data for females and males so we can compare them. As a summary, I would like to highlight that currently there are very limited sex-specific protocols for musculoskeletal surgery and rehabilitation are available, and with my 2 projects, I aim to address this gap. The planned submission dates stands for key milestones for me and also keeps me focusing on my goals. I truly believe that we all have to be innovators in our fields. Therefore, I would like to thank you for your kind attention with one of my favorite quotes: "Do not follow where the path may lead. Go instead where there is no path and leave a trail." Thank you for your kind attention.
Thank you for the presentation. Another question.
I would like to ask a question for your first project. What do you think, what could be the biomechanical reasons behind the ACL graft failures?
Thank you for your question. It's a very relevant question. Despite the high prevalence of dynamic knee valgus, which we usually see in ACL pathomechanism, the injury, I would say that maybe in the landing phases, when the athletes land with limited knee flexion, which means that it's a quadriceps dominant landing, it has a limitation on the hamstring muscles coactivation, which can maybe lead to an altered movement of the landing. And also overpronation of the feet can have an impact on ACL injury, but the overpronation of the feet is also connected to the dynamic knee valgus, so it's kind of like connected, but I would like to say these two. But if we talk about graft-related risks, I would say that graft diameter and the tunnel size also has an impact on the stability and the success rate after ACL reconstruction. And there are different graft types also, autografts, allografts, and hybrid grafts. And based on the literature, the autografts has the higher survival rate.
Thank you.
Thank you.
Thank you for your presentation. I just would like to ask, how would you measure return to sport failure?
Thank you for your question. Return to sport failure is actually very easy to adjust, because when we follow up athletes and we set the 2-year follow-up period as a target in both of our projects, then if we follow up them and they don't return to their pre-activity level of physical activity, then we say that it's a return to sport failure.
And would you think that there are like psychological behavior things that maybe one of the sexes are more eager to come back to sport or less discouraged after an injury?
Thank you. It's a very relevant question. Actually, it's a hot topic because we are aware that kinesiophobia is very relevant among athletes, which means that the athlete is afraid of participating in high intensity movements or physical activities because they are afraid that it's going to be painful for them or they will be re-injured. So yes, it is very important to address this question, and I'm not sure if females or males have a trend towards a higher rate of kinesiophobia, but I believe ACL reconstruction and also the rehabilitation is a multifactorial process, so we always have to involve these kind of questions and investigate it.
Thank you.
Congratulations on your presentation. Regarding the first project, is there currently a different gold standard of treatment regarding the knee injury of women versus men, or will your study be like a first of its nature?
Thank you for your question. Best of my knowledge, there is no sex-specific protocols for knee-related injuries and surgeries. I aim to first address the rehabilitation, which are separately enhanced for males and females. I'm not a surgeon, I'm a physical therapist, so this is more in my scope. But I need to discuss it with the surgeon's perspective. What do they think? Because I know that there are different surgical techniques that they use. There are different incisions and different methods to restore the knee stability. But I'm not sure if they decide one technique because it's more beneficial for female athletes. I think it's just a practice of the surgeon in general.
I understand. Thank you.
Thank you.
Thank you for the great presentation. Have there been any studies before examining the effects of hormones like estrogen and testosterone on the elasticity of the tissues?
Thank you for your question. Yes, there are different studies. I came across with different approaches. I saw an article which was about rodents, and they analyzed female and male species, and they analyzed the laxity of the knee after ACL reconstruction on these animals. But we have to investigate how can we involve these findings in humans. But some biomechanical analyses were available also on humans, and they investigated females. And what the focus was is they actually investigated females with different hormonal phases in their cycle, and they realized that during the landing mechanism there is a difference in knee laxity and the difference in movement pattern in female athletes in the ovulation phase and later on in the luteal and follicular phases. It's different. We have to investigate if this difference is clinically relevant, but it was measurable, so it's a very interesting topic.
Thank you for your presentation. I am one of the guys who went under this kind of surgery, so my question is, what kind of graft are you investigating? Because when I went under, I did a research a bit for myself, and I chose autograft from my patellar ligament. So just wanted to know which kind of graft you're investigating.
Thank you for your question. Yes, there are different graft types, as you mentioned, and both in our projects we decided to choose all of the graft types, and later on we would like to do a subgroup analysis to check of the survival rates of these different graft types.
Okay, thank you.
Thank you.